So our COVID-19 activity remains at a high but stable level. Our number of new cases this past week is about the same. And it is important for us to remember that these are just the tests that get done in a lab that are reported to us. So this does not include all of the at-home tests that we know are going on. So while our COVID-19 activity by lab confirmed tests is about the same as last week, unfortunately, our hospitalizations have increased. We're now actually at the highest level of hospitalizations that we've had since March. So we've had 32 hospitalizations over the last week. 27 of those have been new hospitalizations. So I'm sorry, 28 of those have been new hospitalizations. So I think that it's, this is just a reminder that COVID is here and it's hurting us, and people should continue to do what they need to do to protect themselves. We know that a lot of people are eligible for boosters but haven't gotten their boosters yet, and we would encourage those who are interested in getting vaccinated to make sure that they are up to date. So again, COVID-19 activity is fairly stable from a new cases reported to us. Our hospitalizations are up at 32 cases, 28 of which are new, and that's our highest number since March. But hopefully people are doing what they need to do to protect themselves. The other comment that I just want to make about the hospitalizations, we know that the overwhelming majority of cases in Region 3, which Virginia belongs to, are now associated with the BA.5 subvariant of Omicron. And it does appear that our hospital stays are shorter. So we do think that this is a less virulent strain, but it is certainly a very contagious strain. So that really concludes our update in terms of COVID-19 activity, and I'm happy to take any questions about that. With respect to our hepatitis A activity, we've had one more case to report since last week. We are at 77 new cases from, or cases of hepatitis A since January of 2022, and 56 hospitalizations. So we're continuing to see hepatitis A in our community, high hospitalization rate, and the majority of our cases of hepatitis A are being identified in individuals who use injection drugs. And so with that, I'll open it up to any questions. We do want to remind you that we are holding back to school clinics, back to school vaccination clinics. As Christy likes to say, this is the bread and butter of what we do. We want to make sure that all of our children are up to date before they start the new school year. We don't want anyone to have to delay starting school because they're not up to date with their vaccines. And if you have any questions about that, about our schedules, Christy is happy to talk about that. So with that, I'll open it up to any questions. I don't see any in the chat yet.
Hi, good morning, Dr. Morrow. It's McKinley Struther. Could you repeat the number of hepatitis A cases again?
Yes, so we are currently at 77 cases of hepatitis A since January of 2022. If we look at all the way back to September of 2021, our total case count is at 138. So that includes the outbreak, the restaurant-associated outbreak that we had with Famous Anthony's, as well as 12 additional cases that we had throughout the end of the year. So we've had 77 cases since January of 2022. This compares to an average of 2 to 4 per year most years, and a total of 138 cases if we look back to our first case back in September of last year.
On that front, I know you said majority of the cases are in individuals who use injection drugs. Is that why we're seeing so many at restaurants? I know we had the outbreak at several restaurants last year. We just had a recent case at a restaurant a few weeks ago. Is it because of the spread, unfortunately, because of those who use injection drugs, or is it something else you believe?
Well, I think that it's really important for us to just look at hepatitis A risk factors as a general rule. And so the primary risk factors for hepatitis A, for what we would call community transmission of hepatitis A, are individuals who have substance use disorder, individuals who are unhoused, individuals who are men who have sex with men. In our community, we're seeing overwhelmingly now over 85% of the individuals that we see are individuals who have substance use disorder, including people who use injection drugs. We're also seeing some cases in our incarcerated population. So there is an overlap of different risk factors that we're seeing. We're trying really hard to not make any additional comments about specific individuals. We really don't want to we don't want to invade anyone's privacy by telling what we're seeing in terms of one group versus another, or any individual who's diagnosed, if that makes sense. So what I'd like to do is just focus on the risk factors. As you know, we have had now a total of 4 restaurant workers since last year who've been identified as having hepatitis A. And we just need to look at the risk factors that individuals have. Restaurant workers don't have an increased risk of exposure based on their occupation, but we have to look at any individual and what risk factors they may have with respect to hepatitis A virus, excuse me. So Jean asked a question about, are we recommending hepatitis A vaccine for anyone who is at Billy's? Our investigation, which we did immediately once we were able to identify that there was an individual who worked in a restaurant, we follow the same protocols that we have since the beginning, and that is an on-site inspection to observe what policies are in place, on-site interviews with individuals who are working as well as with the management. And in this case, as in with the other cases, the management has been extremely cooperative, supportive of our investigation. Given the role that the individual, the restaurant worker, had during the infectious period, we do not believe that there was any exposure for the patrons. We did not consider this to be an exposure. That said, we know that we are in a very sensitive point in our outbreak in our community with respect to hepatitis A. And so we feel very strongly that the public has a right to know with respect to what's happening with hepatitis A virus and with our vaccine efforts. I think you all know that we're making a very concerted effort to encourage restaurant workers to get vaccinated. We had a special clinic just for restaurant workers in June. And in every situation where we identify that there is an individual who's worked at a restaurant, we offer on-site vaccinations at the facility, at the food establishment, to try to minimize any barriers for food handlers to get vaccinated. So that's the approach that we took in this case as well. So to reiterate, we are not recommending vaccines specifically for patrons who went to Billy's during that infectious period, because we do not believe that there was any exposure based on extensive interviews and our on-site inspection. That said, anybody who wants to get vaccinated is welcome to come to our clinic. We have a clinic going on right now across the street here from 11 a.m. to 2 p.m. And of course, people who have insurance can go to their primary care providers, they can go to pharmacies, and they can also make an appointment with us here at our health departments. What areas are the most hepatitis A being seen, and how is it fueled by substance use, by drug use? So we're seeing most of our cases are within Roanoke City itself, and there are certain zip codes that we're seeing concentrations of cases. We are working directly with our community-based partners, our community-based organizations who have connections with individuals who are in the different risk factors for hepatitis A. I'm very, very pleased to report that since this began, we've administered over 1,000 doses of hepatitis A vaccine to our most vulnerable community members. So those members who fit into one of the categories that I described. And that is exclusively because we're working with our partners to make sure that we're decreasing barriers for people who have substance use disorder, people who are unhoused, to have access to vaccine. How is hepatitis A transmitted? Through drug use. Hepatitis A is a fecal oral transmitted virus. So when it primarily happens when someone unintentionally, accidentally ingests contaminated food, drinks, or has direct contact with someone who has hepatitis A. So who drinks or eats something that is contaminated by the stool of someone who has hepatitis A or has direct contact with someone who has hepatitis A. When someone is using injection drugs, they may share paraphernalia. There are probably lots of different ways that the transmission can occur, but it can occur through sharing paraphernalia. It can occur through direct contact. And certainly it can occur if someone doesn't have access to hand washing. They can contaminate snacks or drinks that they may be sharing. So I hope that helps. Question about so this is a COVID question. Are there any more questions about hepatitis A? And then I'll answer David's question about COVID. What is being done to get more people vaccinated against hepatitis A? You know, we're really relying on our community partners to help us get the word out, our restaurants to help us get the word out. And certainly we're so thankful for all of you for helping us spread the message that we are in an ongoing outbreak of hepatitis A, and anyone who wants to get vaccinated is eligible to get vaccinated. We strongly encourage people to get vaccine through the pharmacy, through their primary care providers. We're trying to reserve the health department vaccine for those individuals who are uninsured or underinsured, because the vaccine is available for those who have insurance. What are the symptoms of hepatitis A? Hepatitis, by definition, means inflammation of the liver. So hepatitis A is inflammation of the liver caused by the hepatitis A virus. And hepatitis, inflammation of the liver, typically manifests itself by abdominal pain, nausea, vomiting, diarrhea, primarily more diarrhea than vomiting, but anorexia, a profound loss of appetite. And then the classic thing would be yellowing of the whites of the eyes or the skin. That's jaundice, and that's due to the inflammation of the liver and backup of bilirubin. So I hope that answers your question. Also, I'm sorry, I should have said fever and fatigue. With any viral syndrome, you're likely to have fever and fatigue. And Christy put in a long chat about the risk factors. So thank you so much for doing that. Any other questions about hepatitis A before I move to David's question about COVID? All right, I'll keep monitoring the chat. So David asked a question about unreported COVID cases. Anecdotally, it feels like there are a lot of cases out there over the last month or two. Am I concerned that many of these cases indicated by rapid tests just aren't being reported? Yes, absolutely. So it's really important for us to understand that there is a vast difference in the number of cases that are being reported to us today compared to a year ago or even in January. And that's because of the ready availability of at-home tests. So back in 2021 and even back in December, I'm sure you all remember, it was really hard to find at-home test kits. So most people were going to a healthcare facility, going to a pharmacy where they could get a lab done, and those were automatically reported to us. Now we continue to get the reports from doctors' offices, from urgent cares, from pharmacies. But what we're not getting is the at-home tests. And so we know that the 600 plus cases that we reported that were reported to us over the past week are just a small portion of those cases of COVID. We know that there are far more people who are getting tested at home and not reporting those to us. There's no reason to report those to us. So our surveillance for COVID has changed dramatically with the ready availability of COVID-19 tests.
Dr. Morrow, this is Tom.
Hi, Dr.
I've got a question. The AARP was reporting that COVID deaths in Virginia nursing homes have risen for the second straight month in June. Are you finding that the case here? Are we seeing many cases and deaths in long-term facilities, nursing homes? I know during the start of the pandemic, that was some of the worst cases. Are we seeing that here now?
Yeah, well, so I think it's important to just keep in mind, and let me pull those numbers up. I believe, I'm sorry, I don't have those readily available. But I'll pull those up. What we do know is that we are continuing to see deaths associated with COVID-19. I believe we're at 1,021, but I'll verify that. We've had 4 new deaths reported in the past week. And unfortunately, individuals who are in long-term care facilities, even those individuals who are fully vaccinated, even though BA.5, which is the predominant circulating strain, is less virulent, if you're compromised by age and by likely other medical comorbidities, there's still, this is still a dangerous disease for people who are compromised. And so we're going to continue to see deaths associated with COVID-19 as long as we have COVID-19. And those deaths are going to be disproportionately impacting our long-term care facilities because of the individuals who reside in long-term care facilities. And I think that that's why it remains incumbent upon us to do what we can to decrease transmission. Even if I'm not at risk, if I get it and I give it to my 84-year-old mother, she is at risk, even though she's fully vaccinated. So her risk is much, much less because she's fully vaccinated, but she's still at risk because of her age. And we know that vaccines, as a general rule, don't work as well in our older population. So I think that's why it's important for all of us to remain cognizant of the impact that COVID-19 is having.
How are we doing, Dr. Morrow, with schools getting ready to go back? Seems like there's been a lot of reluctance of parents to get the youngest children vaccinated. Are we seeing a reluctance in your health district?
We have not seen a huge uptake in our under 5 population, and that's true across our districts. It's true across the state. I think parents are doing the best. That they're making the best decisions for their families. Certainly, as a public health official, I would strongly encourage anyone who wants to decrease their risk of sickness or death associated with COVID to get vaccinated, including children between 6 months and 5 years. We're going to have to see what happens when school resumes with our pediatric cases. Thankfully, COVID-19 is not as dangerous in children as it is in adults, particularly in older adults, like we were just talking, individuals who live in long-term care facilities. But they do transmit it to people who could be at risk. So I certainly hope that parents are looking at the research, knowing that vaccines are safe, as effective, they're not as effective as we would like them to be, but they are effective at decreasing sickness and death associated with COVID-19. And those families that want to decrease those risks, I certainly encourage them to get their children vaccinated. I think, was there someone else who had a question?
I do have a question about monkeypox. So there has been a lot of conversation on social media of people in our larger cities in the country who have struggled, one, to receive a vaccine. We know that the rollout is still in its early stages, but there have been a lot of barriers in just receiving a test. And also, I mean, it is still fairly new, I guess, but it seems as though healthcare professionals aren't really sure how to handle it either. There have been a lot of stories, and someone I know personally in DC who went to urgent care, went to a dermatologist and their primary care physician, and at every turn got a different answer. So while the cases may not be at the levels they are in, say, New York City, Miami, Washington, DC here, if any of us were to travel, we could be exposed to it. So how would you suggest we go about receiving a test? How do we know if we have it? Like, how do we know it's not just a rash or an allergic reaction? And then, yeah, let's just start there.
Okay. So first, I think it's really important to be aware that monkeypox, which hopefully will get its new name soon, is direct physical contact transmission. There is the theoretical risk of respiratory transmission, but really overwhelmingly, the cases are from direct physical contact. And it's almost exclusively being seen in the population of men who have sex with men, the MSM population. And so I think that the most important thing is for individuals who are risks for getting monkeypox because of being in the category of MSM, it's really important for everybody to be aware of how it's transmitted and to take every precaution that they can to reduce the risk of transmission. With respect to healthcare providers, this is new for us in the United States. There have been a handful of cases in the past, but this is really a new outbreak for us in the United States. And I'll say that I think that Virginia Department of Health, I get copied on all of the provider alerts and emails, and certainly we as local health departments are getting a lot of information every week on monkeypox. So I think that Virginia Department of Health, the central office, is doing a really good job at getting that information out there. We just need to continue to make sure that that information gets to all healthcare providers. In terms of testing, you're right. Hopefully, all healthcare providers know what to do if they have someone who is at risk for monkeypox and who has a rash that is consistent with it. We do know that there are some atypical presentations, and so we hope that everybody is erring on the side of caution and doing the required testing, and rather than assuming it's something else, as you said, perhaps skin dermatitis or something. We really hope that providers are well aware enough to know that if someone is in a high-risk category, that they lower their threshold for testing for monkeypox. In terms of the vaccine, at this point, there's really no indication for widespread distribution of vaccine. It's really targeted. In our district, we have a small number of vaccines that we have available for post-exposure prophylaxis. There isn't really widespread availability for the vaccine. And as the vaccine becomes more available, we're going to work with our community partners who work with the target population to try to access that, to try to decrease barriers and increase access to that vaccine. But at this point, we just don't have the numbers to justify using the very few doses that we have. We need to hold on to those doses for post-exposure prophylaxis should we need it. I hope that answers all of those questions.
No, it absolutely does. Is there any research or data as to why it's affecting the MSN population more than others, being that this is not an STI? Or is it being classified as an STI? Because I've been doing a lot of research to figure out transmission. And it was, even you described it as physical contact, direct physical contact. But that could mean hugging someone who's infected or touching that person if you're cuddled up with someone who is infected. And that is not exclusive to gay men. Everyone cuddles or hugs each other. So why is it that that population seems to be more impacted?
Well, I think that's a great question. It'll be interesting to see whether it's considered in this case to be a primarily, yes, it's direct contact, but is that direct contact primarily associated with sex? And I think that's where we are right now. While it's not a classic STI, it does appear to be almost exclusively involved with sexual practices and when we're looking at the population that's at risk. And it is important, just as we talked about, some of the risk factors with hepatitis A, it's really important not to generalize, but to use our demographic information to inform us. So in this situation, overwhelmingly the individuals who are getting diagnosed with monkeypox are individuals who identify as MSM. Not everybody, but most. And based on the activities that are being identified as the greatest likelihood of transmission, it does appear that this is pretty overwhelmingly associated with sexual activity associated with MSM.
Got it. Thank you so much.
You're so welcome. And I did see, I'm so sorry, Amanda, I missed this earlier. Are we seeing any long-term impacts of COVID-19 for people who have had it more than once? We really, the long COVID data is still quite limited. What we do know is that the data is emerging to show that people who are vaccinated who get COVID are less likely to have long haul or long COVID compared to those who are not. I have not seen any data on whether the increase of repeated infection, whether repeated infection increases the risk of COVID-19. That doesn't mean that it's not out there. I'm not familiar with that data. I haven't seen any of those data.
Hi, Dr. Morrow. It's Leanna with WDBJ7. I was just wondering, going back to COVID cases as well, could you maybe the current case activity that we're seeing right now, while understanding that it is not representing the at-home tests, I wonder if you could just contextualize the data for us and maybe say compared with over the last year, how does our case activity compare, over time?
Well, so if we look over time, and again, we have to be really careful about these numbers because it is apples and orange comparing today's case count to December's case count. But just pulling up our weekly spreadsheet. So for the last 2 weeks, we've been at 650, 670 cases at the per week the last 2 weeks. In January, when we peaked with the Omicron variant, the original Omicron variant, we saw 4,450 cases in 1 week. So it really is quite literally just a fraction of what we were seeing with the Omicron surge. And the Omicron surge was our biggest surge by far. So that, I think that contextualizes a little bit. If we look at last year, so if we look at this time last year, we were reporting between 100 to 400 cases a week between the beginning of July through August, and then it started picking up in August as we were going into our Delta wave. The important thing, though, there is if we looked at our hospitalization data associated with those lower numbers, our hospitalization data were much higher, and that really indicates the more severe disease. So even though we're at higher numbers, 650 this year compared to this time last year, our hospitalizations, if we assume that, and I'm making these numbers up, please don't quote me because I'm totally making these numbers up. Let's say that there's one confirmed case to every 3 cases, and that's hypothetical. We would want to compare those numbers to December, where we had much, much higher hospitalization rates for those numbers. So I think that we are seeing higher number of confirmed cases, which is a portion of the community transmission that's going on. But our hospitalizations, while they're higher than they have been since March, are still much lower than we would have expected to see had this been Delta or the original Omicron.
We have time for
That
one
makes sense.
final question.
And sorry, I just looked to confirm, we are at, unfortunately, I'm so sorry, we are at 1,021 deaths associated with COVID in our community. There's a question about STDs, STIs. That's a really big discussion. What I can tell you is, like many other communities across the country, we are seeing increases in syphilis and other STIs over the last year or so. And we can talk more about that another week if that would be helpful. All right. Any last other questions?
Just again, for context, Dr. Morrow, it's Leanna Scacchetti again. I just wonder, based on what you can maybe tell us, either what the data is showing or anecdotally, again, with context and comparisons, while this variant you're seeing does appear to be more transmissible, can you talk to us about maybe the length of time for which people are symptomatic and the kinds of symptoms they're getting and how that maybe compares with some of our previous variants and subvariants?
I have not heard that for people who get this, it's any different than any of the other variants. One of the challenges for us always is to try to analyze a variant as it's happening, but with respect to onset of symptoms, duration of symptoms, it's going to be highly variable based on the individual's vaccination status, based on their age, based on their other comorbidities. So there's really no way for me to say that this variant is significantly different in characteristics than another variant, other than it appears to be more mild.
Understood. Thanks, Dr. Morrow.
Absolutely. All right, well, thanks for all of the great questions today, and thanks too for helping us continue to inform our community.
Yes, thank you. We appreciate your interest in these public health stories and also making another pitch for the back to school immunizations. We have clinics tonight and tomorrow at Roanoke County Schools. We also have other clinics coming up, and we sent out the flyer about that